Our next presentation is the presence of xerostomia management protocols among MOSDO patients, a cross-sectional study.
All right, thank you. So our project was on the presence of xerostomia and dry mouth and management amongst the MOSDO patients. This is our pilot study, and it's a cross-sectional study. Our faculty mentors were Dr. Zaru and Dr. Vij. Myself, my name is Nick Haste. We had Hunter, Jonathan, Lily, Tyler, and Pyle, and Catherine. Next slide, please. So our clinical research question aim, we're going to use our ATSU MOSDO patients and how prevalent is xerostomia dry mouth and how does it correlate to the patient's age and gender. Is there a correlation between xerostomia reported by the patients or the clinical assessment that we performed on these patients and their assessment of oral dryness? And how do the patients at the clinic manage their xerostomia? The aim is to develop clinical-based guidelines in the prevalence of xerostomia in the St. Louis Dental Center, and if there's any relation between age and gender, and to determine how we manage dry mouth and xerostomia in our patient families. Next slide, please. So an introduction, xerostomia or dry mouth is a oral condition that is frequently encountered on the dental clinic floor. The common cause in the literature is this use of specific medications, which puts polypharmacy patients at a higher risk for xerostomia. Next slide, please. So our research methodology and our study design was a cross-sectional study. It used a chair-side survey that was given to patients after they completed a acceptance waiver for their information. And then we also performed a clinical evaluation at the chair side. Also to note that this wasn't selected for patients that reported only dry mouth. It was also patients that didn't have any reportings of dry mouth. So all patients were included in this study. So the inventory questionnaire is the survey in question. It's a 11-item survey. It's a multi-item questionnaire evaluating for the perceived severity of their dry mouth and asking their current management if they do use one. And then the clinical oral dryness diagnosis scale is a chair-side test that our clinical research team performed. We have 7 researchers. So difficulty in managing, calibrating between the 7 of us, but we had different items that we were looking for, such as signs of oral dryness, which are frothy saliva, dryness of the oral mucosa, and stickiness of the tongue to the mirror or the buccal fold. Participants, again, included all patient research families, not only those that indicated that they had dry mouth. Again, the location is the St. Louis Dental Center. Next slide, please. So here are our results. We had 42 participants in our study. Of those, 18 were female and 24 were male. And this first graph here is the original XI score. That's the self-survey that the patients fill out. 8 patients reported never experiencing xerostomia, 13 occasionally, 9 frequently, and 12 always. The chairside or the CODS score was the chairside exam that was performed by our student researchers. With this, 18 presented as normal, 13 as mild xerostomia, 11 as moderate, and interesting to note, 0 were indicated as severe xerostomia patients. Moving on to the graph in the top right here is, again, the total number of patients, which was 42, and the proportion of the patients on the self-survey was 81% reported some level of xerostomia. Comparing that to with the CODS, which is the chairside study that we performed, 57% reported xerostomia after the research was completed, which is a noticeable difference there. And then we broke it up into if they had either or, which they tested for xerostomia, which was 92%, and then both of them would be 45%. Looking down at table 3 here, we wanted to evaluate if there was any correlation between xerostomia and gender. And the self-survey reported that there was a small difference between them scoring about 2 points higher in the survey for xerostomia, but on the clinical exam, there was almost 0 difference between male and female. And then also our p-values for both tests were not significant. So we believe that there needs to be an increase in the patient population size, or there may not be a correlation between male gender indicating xerostomia. The association, table 4 talks about the association of xerostomia with the subject's age. The p-value for these were not listed as significant, but we believe that there is some correlation based on the correlation coefficients are both positive, which indicates that as you increase in age, your likelihood of having xerostomia also increases. Next slide, please. Going down to the table 6, the management protocols, we asked in the survey also if patients are managing in any way with their xerostomia, and we did have 3 patients that responded that they do manage it, and these are the how they were managing it with Biotene mouth spray or nasal spray, chewing gum, or the dry mouth rinse, or the Prevident dry mouth. Next slide, please. The discussion for our results here is we believe that there is some correlation between age and xerostomia, while we don't believe our findings indicated that gender had any correlation. We do believe that we need to increase the number of patients that are tested with our survey. And there was also a large variance between what patients self-reported xerostomia and the clinical chairside test. And that could be one of 2 reasons. Our hypotheses is that either patients are over-reporting xerostomia, or that at the chairside, they're on that snapshot of the day, they're not presenting with xerostomia, and the patient knows themselves better. So those are our 2 working ideas of why there may be a huge difference there. And then also to the correlation of as you increase in age, polypharmacy increases, which is linked to a greater risk of xerostomia. Next slide. So the formally accepted management protocols we listed here, systemic Sialogs, pilocarpine, intraoral topical agents, which is chewing sugar-free gum or spray, and then also changing medications, lowering the dose of their current drug, or choosing less xerogenic drugs. Next slide. Conclusion, limitations include our patient population size that we tested. We tested 42 individuals. And then also, our group was one of a larger group, so we had 7 researchers. So calibrating among 7 researchers could improve our findings better in the future. We believe we set up the necessary framework for a research project to continue in the future, to get more data and patients to have more meaningful data. Next slide, please. Acknowledgements, we'd like to thank Dr. Zaru and Dr. Vij, and then thank our biostatistician, Mary Wang, and thank you for your analysis. And next slide. And here are our references, and I'll open it up for questions.